be heard? Okay, great. Wonderful. I don't know if there is a way for me to see the attendee list, so I'm not sure if folks are still trickling in. But I think that we will, just in the interest of time, go ahead and get started. For those of you who don't know me, my name is Veena Shankaran, and we're thrilled to welcome you all to this study kickoff meeting for the credit study S1912CD, randomized trial addressing cancer-related financial hardship through delivery of a proactive financial navigation intervention. And next slide. Okay, here's our agenda for the meeting. So we want to have save a good chunk of time for Q&A, because I'm sure those of you in attendance will have lots of questions, just both along the study design, but also all of the operational details, eligibility, and so on. So we want to keep probably a good half an hour set aside for that. But we're going to start with a overview of the study, and I'd like to acknowledge, first of all, a huge study team that's been really working behind the scenes to get this study close to activation, which we hope will be in June of this year. So in just about a month and a half away. And then would like to, introduce the folks who will be presenting today. So I'll be kicking us off with an introduction to the study. We have Ari Bell-Brown, who's the project manager for the study based at the Hutch, who will be going over some of the operational details and study logistics. And then we have our partner organizations who are really going to be delivering this intervention to patients and caregivers. So we have Consumer Education and Training Services, or CENS, which is a Seattle-based organization, and Judge Karen Overstreet will be talking about her organization and the role that they'll play in the study. And then Patient Advocate Foundation, or PAF. Jennifer Obenchain from PAF will be talking about PAF's role in this study. And then Barbara Segarra Vasquez, who's the patient advocate, who's been involved with the study from the get-go, will be giving us some pointers and tips on how to approach participants about this study. And then, as I said before, we'll have a Q&A at the end. And just in terms of housekeeping, there's no, you can't just unmute yourself and ask the question. You'll actually have to type the question into the chat or the Q&A box, and then we'll read the questions out loud at the end and answer them. Okay, next slide. All right, so I'm going to go over a quick study introduction and overview. I am, just a brief introduction, I'm a GI medical oncologist, so I'm pretty clinically active, and I co-direct the Hutchinson Institute for Cancer Outcomes Research, where our focus is really on health economics, cost of care, and financial toxicity. And we've been really interested in this topic of financial toxicity and financial navigation for many years. Next slide. And I think just in terms of the problem, I think most of us who are participating in this call are aware that financial toxicity is a problem that patients and patients face, and it does seem to affect their treatment course and outcomes in significant ways. But what we haven't recognized as much previously, and what we're learning more about now, is that the financial issues around cancer care can affect caregivers as well. And that really, in thinking sort of holistically about interventions and solving this problem, we really need to recognize that financial issues are a household problem. They affect patients and caregivers, and thus need to be intervened upon at that level. Next slide. So over the course of many years, we've worked with both PAF and CENS to develop a financial navigation program and implement that program at our center here in Seattle. And based on our preliminary work, our goal is to expand this program to patients across the country and try and understand the impact of this program on a number of measures, including financial hardship, quality of life, financial worry, caregiver burden, treatment adherence, and healthcare utilization through a randomized pragmatic study. Next slide. We plan to activate this study in, it's actually the timeline's a little bit different than what's listed here, in June of 2021, and then likely shift by a month. June to July 2021 will be our first participant registered on the study. Next slide. Here's the schema. So I just mentioned what our objectives are and what we're going to be, how we're going to be enrolling and randomizing patients. So patients and spouses will be enrolled registered and enrolled at a dyad level. So both the patient and spouse caregiver will be receiving the same arm of the study. So they'll be randomized to either control, which will be financial literacy training consisting of online videos, video modules that they need to, they have the opportunity to watch at their convenience, or an intervention, which will be the same financial literacy videos in combination with counseling, indirect and non-medical cost assistance, and direct medical cost and healthcare coverage assistance delivered by Censor and PAF, and you'll hear a little bit more about that later. The intervention will be delivered proactively, meaning that patients and caregivers will be actually contacted by Censor and PAF once a month for 6 months. And then, of course, patients and caregivers can reach out as needed in between those time points. And this is different from the standard of care, which is really just, people going through the normal channels in the clinic or through community resources to get assistance and having to take that initiative on themselves. We're going to be administering surveys at multiple time points, so at baseline, 3 months, 6 months, and 12 months in order to assess our outcomes. And we're going to be pulling credit data at all of these time points as well on both the patient and the spouse. And this is how we are going to be primarily assessing the impact of our intervention on financial hardship. Next slide. Here are the eligibility criteria. So first off, we're going to be enrolling a total of 536 dyads for a total of 1,072 subjects overall. Let's talk about the patients first. So the patient eligibility criteria are as follows. So they have to be 18 and older. They have to be seen and treated at an NCORP site. We're allowing both patients with metastatic solid tumors requiring treatment or hematologic cancers requiring treatment. They need to be within 120 days of diagnosis. The key here is that the hematologic cancer, they do need to require treatment for that. We're not enrolling people who are on, surveillance or watchful waiting, which can sometimes be the case for many years for patients. We are allowing patients who may have a prior earlier stage diagnosis of solid tumor, as long as they are now presenting within 120 days of the first presentation of metastatic disease, and that the earlier stage diagnosis happened 6 months or prior before the metastatic diagnosis. Patients can be English or Spanish speaking. All the materials will be translated into Spanish, and we will have interaction by Spanish speaking counselors and navigators directly with Spanish speaking participants. Next slide. In terms of prior and current therapy, so we're requiring that people either start anti-cancer therapy within 60 days prior to registration, or be scheduled or planning to start within 30 days after registration. So just allowing a window of time around registration to have started or be starting therapy. And importantly, we're allowing anyone to be enrolled on any other clinical trial that may be of benefit or interest to them. Can we go back to the previous slide? Right. In terms of the spouse caregivers, so first, we've limited the caregiver enrollment to spouses primarily because we want to be sure that the financial relationship is consistent between the patient and the caregiver. And spouses will be eligible as long as they're 18 or over. They should be living in the same household with the patient, and they should be legally married and or filing taxes as married, filing jointly. And both the patients and spouses will need to provide their Social Security number in order for us to be able to pull credit data. Next slide. Next slide. So I'm going to turn it over to Ari, who's the project manager on the study, to go over the operational details.
Thank you, Vina. And before I get started, it looks like Kate Gallagher had a question in here about participants in the control arm who organically get linked to PAF, and if we'll control for that support. And the answer to your question, Kate, is that on the follow-up questionnaires, we will be asking control arm participants if they were linked with any financial resources, and then they'll have space to fill out what those are. So that's how we'll evaluate that. Okay. And let me know, Kate, if you have further questions about that. Happy to answer. So hi, everyone. I'm Ari Bell-Brown. I'm the project manager for this project. I work at HiCore with Dr. Shankaran, and I will be reviewing some of the operational details for this project. Next slide, please. So a couple of things to think about before you start enrolling participants. The first is that this project is limited to NCORE sites. So we ask that you confirm your NCORE status, and we provided a link there to do that. We also have a site survey that we're asking sites to fill out before enrolling any participants. That will describe the existing financial counseling resources that are available at your site. The survey is really short, it's 10 questions. And it will be completed through REDCap, and then there's a confirmation page that will be uploaded through the CTSU regulatory submission portal. Instructions for accessing the survey are in the protocol in section 13.2. You can also reach out to our team at credit@fredhutch.org, and we'll put that up later in the slide so you don't have to remember it. And there's some instructions here on how to access the regulatory submission portal login. Next slide, please. And this is just an example of what that completion certificate looks like. You'll only need to fill out one per CTEP ID that's participating. And if you go in and say someone else on your site has filled it out and you put in your CTEP ID, it will tell you you don't need to fill it out. So there shouldn't be any duplication there. Next slide, please. This is kind of an overview of the participant management for this study. So we're asking sites to approach all eligible patients and their spouse caregivers, and evaluate their interest, obtain consent. You can do that either in person or remotely given the COVID situation, and confirm eligibility criteria are met. Then you'll register the consented eligible participants in open. Spouses and patients will need to be registered separately, and we'll discuss that a little bit more in a further slide. And then you'll collect and submit the data at study time points. Next slide, please. So recruitment, site staff CRAs will screen, approach, and consent patient and spouse caregivers in person or remotely. We want to encourage you to approach all patients who qualify for this study who meet that eligibility criteria, whether there is a perceived financial need or not. We've learned from a lot of our pilot studies that even if patients don't have perceived financial needs through this financial counseling, it turns out that there are a lot of financial needs. So we would like you to keep an open mind there. If it's possible, patients and spouses will be consented on the same day, but there's some guidance in the protocol on that if you cannot consent them on the same day. We are requiring that both patient and spouse agree to participate in this study, so both of them have to consent to participate and be eligible. Our recruitment timeline is about 2 years. As Vina mentioned, it's being pushed out a little bit from May, so we'll say approximately June of this year to July of 2023. Next slide, please. And the location of study documents can be found on the CTSU website. One document we've created that we hope will be helpful to you guys is a talking points document that provides tips on recruitment strategies, how to approach patients and caregivers. We recognize that this is a personal issue that a lot of people are dealing with, and some of it might be a little sensitive. So we have some pointers there, and then some key points to share with potential study participants. Next slide, please. So for registration, as I mentioned before, both the patient and the spouse caregiver need to agree to participate to be eligible in this study. They will be registered separately, and then the CRA will link the patient and caregiver registrations. There are instructions on how to do that in section 5.5 of the Open Site User Guide. And open is not my specialty, so sorry if I'm butchering that, but there are instructions on how to do that. And we did want to note that while both patients and spouses are required to be a part of the first call with Censor PAF if they're randomized to the intervention arm, we will allow spouses to continue participating and receive financial counseling if the patient dies or no longer wants to participate. So while they both should be present for that first call, we will allow spouses to continue in participation if one of those events happens. And next slide, please. So some tips on data collection. We think the questionnaire should take about 30 to 60 minutes to complete each time. And I'll show you the data collection calendar in a moment here so you can see the time points. The form submission guidelines are found in the protocol in section 14.0. And the off-protocol notice will need to be submitted for both the patient and the spouse at 12 months if it wasn't previously submitted for a different reason. And that's covered in the protocol in section 7.12. And next slide, please. So this is just an overview of the data collection time points for the participant completed forms. They've been broken up into patient questionnaires, spouse questionnaires, and then there's questionnaires that they'll answer together. So there's some questions that we want them to answer jointly. And I won't go through this in detail, it's in the protocol, but we just wanted to show you guys an overview. Next slide, please. And then this is the data collection time points for the site completed forms. And then we'll also be pulling credit data at baseline, 3 months, 6 months, and 12 months, and off protocol if that happens before 12 months for any reason. And it is a soft pull, so it doesn't impact the patient or the spouse's credit score, which we cover in the consent form. Next slide, please. So both the usual care and the intervention arms will be receiving this financial literacy training. And this is 10 short web-based training videos that cover a variety of video topics related to financial literacy. We're encouraging dyads to watch the videos of interest to them. So, some people might not want to know about decoding medical bills, but explanation of benefits might be interesting to them. So they can kind of pick and choose what they want to learn more about. We're encouraging them to watch them within 2 weeks, but it is optional for them, so it's not a requirement of the study. The videos are available in both English and Spanish, and we'll ask the dyads on their first questionnaire about which videos they accessed, if any, so we can get some data on that. Next slide, please. And so for the dyads randomized to the intervention arm, they'll receive this proactive financial counseling from Cens and PAF that Vina discussed before. And we are fortunate to have Judge Overstreet here from Cens and Jennifer Obenchain here from PAF to discuss a little bit more about their organizations and what they'll specifically be providing in this study. They will be meeting with the participants once a month for 6 months. And next slide, please. I will turn it over to Judge Overstreet to talk with you all about Cens.
Thank you, Ari. I think you can imagine, those of you who are in the medical business, that as a bankruptcy judge for 21 years, I saw my fair share of the catastrophic financial results of not just cancer diagnosis, but all kinds of medical problems. So I like to think of my role in these kinds of programs as to really help you understand that this is real. This really happens to people. People lose their homes. They lose their life savings. They end up in a financial disaster as a result of medical problems like cancer. Sense was actually born a little over 25 years ago now, and we are a group of all volunteers except for our paid executive director. Next slide, please. And as professionals, we are lawyers, we are financial professionals, court staff, judges. We are seeing in our daily lives and we're seeing in our work lives really the aftermath of financial disaster. And our goal as an organization when we started some 25 years ago was really to start pushing out some financial education into the community with the hope that it might change some of these results or some of the things that we see in the after the fact bankruptcy world. So we have developed over the years a number of programs, debt clinics. We have a high school program. We talk to seniors about wise financing, former justice involved individuals, student loans. And so cancer education and counseling is really, was really and is really a natural for us. I've been working with the Hutch now. I retired in 2015, but even before that, I started working with the Hutch on looking at these issues and really trying to figure out what can we do to help people in this situation. Next slide, please. So the role of Sense really in this study is to provide the financial counselors, and we are staffed with financial professionals who are certified financial professionals, lawyers. We have a team of Spanish-speaking lawyers, all of whom have experience in this space. Now, as part of the study, we are not committing to provide legal advice, but instead our counselors will be proactively working with patients to look at, if you look at the slide, really budget planning. Can we foresee what expenses they will have in the coming year and year after? How can we manage those expenses with the resources that they have? Are there some additional resources we could bring to light? What are their employment circumstances going to be? Can they work? Will they lose a job? Can the non-spouse add some income? We talk about financial and legal planning. Are you ready for end of life issues? If you're not, good time to do that is at the beginning when you're still feeling well enough to address those issues. So the goal would be to try to proactively give people whatever benefit they can from their existing resources so that they don't end up in the worst financial condition. And what's the next slide, please? So I think that's, in a nutshell, kind of what we are going to do. This is something that we have been doing for a while as part of previous studies and as part of our community efforts. And I do hope that we will get to the point where we find that it makes a difference. So with that, I will turn it over to Jennifer from PAF. And I'll take questions at the end if anybody has any. Thanks.
Perfect. Thank you. Good afternoon, everybody. It's definitely wonderful to be here and serving as a panelist. I'm happy to share a lot about our services, and those of you that don't know a lot about Patient Advocate Foundation, we are a nonprofit organization that provides case management services to those in the United States that have chronic and life-threatening and debilitating illnesses. As we all know, once somebody has heard that they have been diagnosed with something, sometimes a lot of the barriers of access, financial toxicity, a lot of things happen to come up with patients. How am I going to continue to work? How am I going to support my family? Will I be able to work if I'm getting treatment? So we know a lot of the times patients definitely do go through so many things when they go through their illnesses. So next slide, please. So on the slide, we definitely have a couple of 3 areas of buckets to show the different types of support that we do provide to patients. A lot of it comes down to, again, that reducing that financial burden. And just to kind of touch a few little pieces on here of sometimes it is proactively trying to hand hold them and have them understand what resources are there. And sometimes we have to look at not only just locally, but also at a regional and national organizations that can provide some financial support to the patients, whether it's trying to afford, as Judge Overstreet suggested earlier, their mortgage payments, and sometimes it's their rent, how they're going to be able to afford food, trying to help them understand what ADA accommodations or FMLA rules and regulations there are, trying to help them engage, and even if we have to, looking at what their short-term and what their long-term disabilities are, and what that looks like, and if they have to appeal it, and even just application for those. A lot of questions do come around that as well too. We'll also get into where we have to look at the enrollment into different types of insurance, if they're uninsured, what they're eligible for, if there's open enrollment, looking at charity and other social programs. A lot of the times, patients who are diagnosed, they truly just don't know if they're going to be able to continue to work. What would that paid leave look like? Can they afford their COBRA? And if I can't afford my COBRA, what am I going to do at this point? So a lot of the times we have to do a lot of not only just education, but really providing the patients with the detailed information, kind of outlining those steps for them and trying to help them make the right choices. Also, the other piece too, with the providing the insurance navigation piece, we also will look at their benefit plans. We will help them determine if there might be a billing and a coding issue, especially if they're getting those medical bills that are continuously coming in as well too. Making sure that, if they do have to get treatment, looking at what's maybe an in-network provider versus an out-of-network provider. Sometimes it gets down to looking at treatment decisions and clinical trial options for them, and really what's best for them, and obviously with their treating physician as well too. A lot of the times when it comes down to options for treatments, we will help with the appeals process as well. A lot of the times we actually will go through each level of that appeals process with the patient. And really kind of navigate through, because sometimes that is just completely overwhelming to them. My insurance denied this. I can't get access to this. What do I do next? The doctor's office obviously is trying to do, and providers are doing everything we can. We always like to try to be that administrative assistant to them as well too, and trying to get patients access as well. And that's for medications as well too, trying to see what plans for their Medicare recipients and their Part D plans, and really kind of navigating through that with them. So next slide for me, please. So for PAF's role in this, our case managers will definitely provide that direct patient services support to them. Obviously, our goal is to help eliminate those obstacles for them to get access to their prescribed quality care, looking at those overall pictures. And again, this kind of buckets that a little bit in simpler terms, where again, looking at those out-of-pocket expenses that they might be occurring, or even what they may come into. Right now, they might be okay and everything's going okay. But as we know, those things can change at any time. Their health can decline. We just don't ever know. So definitely, again, those employment protections and benefits, looking at disability options, especially if they're not going to be able to continue to work, not only with Social Security, but again, that short-term and long-term disability. And of course, sometimes those just out-of-pocket expenses do add up, especially going back and forth to the doctor's office. How am I going to pay for my gas? Not only that, but there's a copay if we can help with any, programs that might be available to help them. And again, just trying to eliminate some of that stress for them, and trying to overview what's best for them, what's available, and how we can be here to help them. So next slide. Oh, I'm sorry. Well, thank you. And again, I'll be at the end of the session as well too for any questions that you guys might have for me. So.
Hi, I'm Barbara Segarra Vasquez. I'm the patient advocate for this study, but I'm also a two-time breast cancer survivor. So I first want to start saying that I'm very enthusiastic about this study. More happy because it's going to be in Spanish. I'm from Puerto Rico, so I really, I was blessed when I was diagnosed that I spoke the language, that all of the people here in Puerto Rico speaks my language, and I work at the university, so I had insurance and everything. But I know all the financial burden patients have. So this will be excellent for our patients. And another thing, even if the patient is not randomized for intervention, the video themselves, and once I think maybe when the patients start, the participants start watching the first one, will want to watch all of them, are very short, but are very, after 17 years of being diagnosed, I learned a lot just reading the scripts and all the things. So those in the intervention having the support of Sense and Pat is going to be amazing. Next slide, please. So I just thought of out of my head some tips of how to approach patients. And as Addie said, it's important to approach every patient. We don't know what everybody, you know, we can all dress up and seem like we're doing fine. But as it was mentioned, even out of pocket can add up. So it's important for patients to understand that you're approaching everyone, that you didn't just single out them because you thought they needed. So I think that's important. I think it should be emphasized that cancer is a family issue, especially if a patient is just beginning with this journey. And that's why it's important to include spouses and explain how important it is for the spouse to actively participate in these financial issue, because it's a house issue that they're going to be facing. The person who's going to activate or invite patient to participate, I think the most important thing is when and how we approach patients. You know, when you're diagnosed, your head is only thinking about what is going to happen to you, what's going to happen to your children, and other things. And when I was diagnosed, I even had to change a surgeon, but they approached me with a study, and I didn't even know what a clinical trial was. So I think most of our patients don't even know that. So when they hear clinical trials, they even get scared of the word itself. So I think it's important to have, you know, the time and see when we approach them, because if they're just thinking about their treatment and how they're going to afford it, they won't want to listen to anything else. And another thing, even we are using the word burden, but, you know, as scientists, we usually use financial toxicity. As patients, we don't want to hear that word toxicity anywhere but the one we have to face because of the treatments. Next one, please. Patients should know, even if they are not, as I mentioned, randomized in intervention, they will receive important information through the videos and how to decode the billing system. I learned all those things when I was just reading at the script. So I think it's important for them to realize it's good for them. I think you have to give time for patients to ask questions, especially two issues are very delicate in this study, and it's about their social security number, where everybody is scared even though we put it everywhere, and second, about the credit data. You know, how is this gonna be, I'm gonna be penalized and other things, and we have it said it won't, but they have to be reassured about that. And if possible, when patient is invited to participate, as they were mentioned, having both of them together, and even if they don't consent that same day, because I think, you know, sometimes when we approach patients to consent and we want them to do it right there, I think it's very difficult because you're still trying to process all this. And when you're talking to spouses, you know, invite them, because a patient could be willing to do this, but it's important for the spouse to understand. And it's also a cultural thing. Like for Latinos, somebody saying that you're gonna get into my financial business is gonna be offensive or whatever. So I think we have to give time. And if the patient is alone, try to ask what they think the husband will ask. And so you guys can provide the information before the husband or the other spouse is invited to participate. So these are just general. Ari said there's a guide of how to do it, so, and will be available. And I just want to take the time to thank Vina. I will never be able to pronounce her last name, so Vina, sorry, for always for having me involved in this project since the beginning. I'm excited to see the people that we recruit and participate. So thank you.
Thanks so much, Barbara, and for all of your presentations. I think we're done with slides.
There's a couple.
Oh, yes, a couple more. Okay, so this is actually a very important slide. This is the entire study team, all of the investigators, co-investigators, folks at the Hutch, SWOG, CRAB, our collaborators who've been really involved in actually in launching this project over the last several years, from grant submission to where we are now. So just want to acknowledge everyone's hard work. Next slide. Great. So this is anyone is always welcome to email me directly at vshank@uw.edu. But we do have a special email for any questions pertaining to the study, eligibility, and so on, and that is credit@fredhutch.org. And that email will go to myself, Ari, Debbie Delaney, and Kate Watabayashi, all of us at Fred Hutch. Oh, Ari, maybe I'm saying the wrong thing. Should they email credit or cancer control question at CRAB?
No, you're saying the right thing. Yeah, feel free to reach out to our team at any time. After activation, that cancer control question at crab.org can answer questions about eligibility and data submission. But if anytime you email credit and it needs to go to cancer control question, we're happy to direct it to the right place. So happy to triage those for you guys.
Super, thanks, Ari. Okay, well, thank to all the panelists for those comments and for your presentations. Really appreciate it. We have a good 25 minutes or so for Q&A. So I'll ask folks to just type your questions into the chat Q&A, actually into the Q&A, and we will answer them.
And we do have one question about if there is a plan to incorporate any LAPS sites, LAPS sites, to participate in the study. And the answer is no. The trial is open to NCORE sites only, since it's a CCDR study and the NCOREs have specific CCDR funding. So that's why it's limited to NCORE sites.
Vina, I'd like to follow up just on one thing, if I can, that Barbara said that I think is really important. And that is that people are very private about their finances. It's a sense of pride and security, and it can be demoralizing to have to admit that they're afraid of what might happen with their finances. And I do think it is important, though, to understand that even for people who are financially well off and have good insurance, we have found in prior studies that mentally, psychologically, they feel better just hearing someone say, I have looked at your budget, I've looked at your resources, and I agree with you. You're fine. You're going to be fine. And even that is of benefit to people. But I do agree with Barbara that there is a great sensitivity that needs to be shown when approaching people about their finances.
Yeah, great points. The other, adding to that, I think that we've been reluctant to limit the enrollment of the study only to people who meet some criteria for financial hardship, because first of all, that raises the, might make people feel uncomfortable with the fact that they are eligible for such a study, but also we know that this problem crosses, all income levels, all insurance types, all socioeconomic strata. There is a question in the chat, what if your patient is single? Asked by Lori Parker. So good question. So we are only enrolling for this study patients who have spouse caregivers, because primarily for driven by scientific reasons, truly, in order to measure the household financial hardship. This is not to say that people who are single would not benefit from this kind of program. In fact, one could argue that they might benefit even more without they don't have the benefit of a caregiver involved with them. So I hope that we'll be able to do more studies like this in broader patient populations in the future. Still waiting for some more questions in the chat. Any other thoughts or questions from the panelists on, or anyone else on the study team that came up while you were listening?
I don't have anything new to add. I really have to say it is, again, goes back to having with the patient, having the family there and coming together. It is a family thing that happens in each household. And we have seen it for many years, just as Judge Overstreet stated about how it is hard to want to go over your financials or what you have in savings and just in fear. It is a lot, and a lot of the times the patients truly have to make sure you have a rapport with them and that they feel comfortable with you and going over that information too. So I wanted to agree with that and state that is a really good point as well too. So.
Thank you, Jennifer. So I think I was not seeing some of the questions in the chat. So there are, let's see. There is a question, how do you best describe the soft credit check when many are uncomfortable with someone running or checking their credit? So this actually came up during S1912CD as well, because we had to check credit reports on all the patients who entered that study. And for that study, we had a memorandum from the TransUnion, the credit agency, that a soft credit check or a credit check for research purposes would not affect their credit. It's not like an inquiry which would show up and potentially affect their credit negatively. We were hoping to get something similar for this study. I think, and Ari, you can comment if we can simply use that same letter. We're hoping to update it so that we can distribute it to sites to present to patients when they enroll.
Yeah, we'll need to put it through IRB review before that, but we are going to update that letter for sites to distribute.
Okay, there's a question. How would the financial navigation program tie in with our own robust financial counseling at our clinic? Can they do both the study and the financial counseling locally? The answer to that is yes. You can make use of whatever financial services you have in the clinic. This is part of our rationale for wanting to do the site survey at the beginning so that we can control for some of these factors when we look at the results. So any site participating will be asked to fill out as part of the, to open the study, will be asked to describe what services you have at your clinic.
And Vina, that's most helpful to us as well, because people have to recognize that we're all of our volunteers are here in Seattle, and they'll be doing counseling via Zoom and telephone with patients who are in other parts of the country. And we're not necessarily going to be familiar with what local resources are available. So that in-house, on-site financial assistance at the institution is actually, I think, a very helpful and needed additional resource.
Yeah, and Judge Overstreet just answered one of the questions about how the counseling sessions would be administered. So the first counseling session, we are asking that that's done over phone or video conference. The subsequent sessions are really up to the participant. They can be by phone, by video conference, by email if they just want a quick check-in. And we're requiring both the spouse and the patient to participate in the first session, but the subsequent sessions, if just the patient wants to participate in one or just the spouse wants to participate in one, that's totally acceptable. There's also a question about if the number of participating NCORE sites will be limited, and the answer is no to that.
Ari, there's a question here about whether the protocol and other study documents have been posted on CTSU already. If not,
They have not yet, no. The pre-activation revision is going in hopefully this week or next week. And then when that's approved, that's when the study documents will be available on the CTSU site. And if there's any questions in the interim before those documents are available, again, please feel free to reach out to credit@fredhutch.org, or if you'd like to fill out the site survey, ahead of time, we're happy to send you the link if you reach out to credit@fredhutch.org.
I think we missed one follow-on to a good question too. Somebody remarked that they agree the phrase or the words financial toxicity are scary and we shouldn't use them, and have asked, what are some other words that we could use? And one thought that comes to my mind is, what if we talk about financial security instead, something positive? Making sure that you're financially secure, that you feel financially comfortable, getting financial assurance. So my advice would be to put it more in the positive. You may not have any financial problems at all, but it will make you feel better and your family better to have a sense that you are secure, and to get that confirmation that you are secure, and maybe get some ideas about other things that might put you in an even stronger financial position. So that's kind of how I would approach it, with more positive words.
I love that word, Judge. I love it.
And to answer the question about if that's in the talking points, I'm not sure that it is yet, but we will certainly add it if it's not, to make sure that that language is in there for your reference before it gets uploaded to CTSU. And Blake asked, after a patient is registered, when should they expect to be contacted by Censor PAF Navigators? And it's within 14 days of registration that they'll get an initial reach out, introducing themselves, and then setting up that first session.
But just to add on to that, Ari, something that we've been talking about is, those of you who are consenting patients, it's really helpful that they get their baseline surveys in right away, because that's so helpful to the counselors to actually be able to see answers to some of those baseline questions before having the first meeting. Otherwise, that counselor is basically asking questions that would have been in the baseline survey. And we want to make this simple for participants. We want them not to be asked the same questions multiple times. So that initial round of surveys that the participants fill out, those are really important that we impress upon them that they should do those as promptly as they can.
Yeah, thank you, Judge Overstreet.
Yeah, absolutely.
There's a question, are you worried at all that people won't have internet access, and is that an eligibility criteria? Do you want me to take that? Or it's not an eligibility criteria, and participants have a choice of how they want to be contacted. So for the initial session, they would need a phone at least. They don't have to do a video conference or a web-based platform for that.
I think we can work around that. I mean, most people do have an internet connection, but certainly our counselors are used to dealing with people by phone. It's a little harder if you can't see their documents. But I don't think that if someone doesn't have an internet connection, I think we just have to work around that.
Ari, will participants have the option to watch the videos in the clinic?
Yes, although it depends on the clinic having access to a tablet to show the videos to them. So we do say in the protocol that we would prefer that that's an option for participants, but some clinics, I'm not sure if all clinics have access to a tablet to show those videos in clinic. We do have handouts of the videos if there's a participant that would not be able to access them online and your clinic doesn't have a tablet. We could send you the handouts that you could give the participant. That's also an option.
There are a number of questions here, are just kind of going through the ones I missed earlier in the chat on whether patients and caregivers have to participate together or not. I think you already addressed that, but if you want to just kind of repeat that quickly.
Yeah. Yeah, so we are requiring that both the spouse and the patient consent to the study and participate in the initial counseling session if they are randomized to the intervention arm. Subsequent sessions, they can choose if just one wants to participate in the session. If they both want to, they can also choose if they prefer just to do like an email update 1 month if they don't necessarily need a full phone call. So it's really tailorable after that first session.
After a patient is registered, when should they expect to be contacted by Censor or PAF?
I think we talked about that one. We said within the first 14 days, but going back to what Ari just said, sometimes the advice we give is that a capable caregiver should take over the financial aspects of the problem. And the participant patient should be free just to worry about the treatment they're going to go through. And when we do have a couple where there is a caregiver who is willing to take on the financial part of it, we almost do want the participant then to bow out and let the caregiver go forward. So that is one strategy when you have a capable caregiver who's ready to do that.
Points.
And Kelly requested in the chat that we send over the site survey ahead of time, which I'm happy to do, Kelly. If anyone else would like it ahead of time, please feel free to reach out to us at credit@fredhutch.org.
Okay, there's a question. Do we know if caregiver registrations will count towards ACOS accreditation for sites, and will caregiver and patient count each as a CCDR enrollment for grant reporting? I don't know the exact answer to this question. I'll turn it over to anyone else who might. I believe that caregivers and patients count separately as enrollees for grant reporting purposes. They are a study subject, but if anyone has a more sophisticated answer, chime in.
I'm not sure if Kate Castro is on and able to answer.
Just saw a note from Kate. She says, yes, the accrual will count for NCOR reporting purposes, both accruals. So confirm that. Thank you, Kate.
Great, thank you.
And I just want to make a comment while you keep looking, and not only for this study, as I mentioned when I was presenting, I think we should always have information in our clinics about what a clinical trial is and how it is important to participate in every language, just for people to hear about it before they need it. Because once you are in this journey, just to hear another new word or something to think about when you have never heard about it, I think is important. So taking time to having, this is something that the patient advocates, we talk all the time, having this information available all the time. So when we approach patients, they're not guinea pigs like many think they still are.
Absolutely. Great point, Barbara.
Lori asked if we allow phone consent, and yes, for this study, there is a remote consent available and it's detailed in the protocol.
Ari, do you see anything that we didn't address in the chat here? I think we've tackled most of these questions.
Don't see any. Oh, something just came in.
Something new in the chat.
Yeah. Would younger patients who are between ages 18 and 26 who are still covered on their parental medical insurance also be eligible if their coverage costs and medical copays are still covered by their parents? since they and their spouse may still receive some parental support. Would that make some younger dyads ineligible? So if they're covered by their parents, but they're still married, are they ineligible? And
I mean,
I believe the answer is no, but
yeah, they'd still be eligible. You know, I think that as long as they're married and they meet all the other eligibility criteria, we'll be collecting information about insurance, and they definitely could benefit too from financial navigation and counseling for all of the other expenses that go into their cancer care.
And then there's a couple of questions about if a patient is divorced and some different situations about how they're cared for. Would they still be eligible as a couple if they live together? And the eligibility criteria is that if they are filing their taxes as married filed jointly, that would make them eligible. So if they're living together but not filing that way, then they're not eligible.
Any options for info for blind or deaf patients? Nothing specific to the study, though. Whatever accommodations that would normally be done to enroll patients on study, we could apply here.
The protocol provide recruitment materials such as a brochure or flyer. We have not developed one yet, but we will likely develop a brochure for sites and distribute that.
Marie, we do have a study brochure.
Oh, you do? Oh, great.
In Spanish and
Debbie.
English.
Thank you, Debbie.
So there's a question about the site survey information. So I think this came from Judy. Judy, can I ask that you just send us an email to the credit@fredhutch.org, and then we can send you the survey so you can see the questions. It is a patient randomized study, not a cluster randomized study. So we just need that information one time prior to the site being able to activate.
And Kelly, yes, a verbal report from a patient for how they file their taxes is okay for eligibility.
Okay, I think we have a couple minutes left. Lori's reminding everyone that we have to, questions need to be posted to all attendees. I noticed that on the chat, it's if you move your mouse too quickly, it'll change the two for the chat. Okay, well, I don't see any more questions coming in, and we are at the end of our time here pretty much. So we can give people maybe a minute back. I just want to thank you all for attending and for your wonderful questions. So I would ask you to just email us if anything comes up. We will get the site questionnaires out to those of you who have requested. And, you know, hopefully in June, many of you will be ready and willing and excited to participate. And we're looking forward to it as well. All right. Thank you all so much.
Thank you.
Perfect. Thanks,
Thank you.
everybody.
Bye-bye.